The only thing you have any control over is the work that you choose to do at any given time. The outcome of your efforts is not in your hands.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org.
Hello, everyone. It is my immense pleasure today to introduce Dr. Ankur Kalra. Dr. Ankur Kalra is a qualified interventional cardiologist and associate professor of medicine. Ankur has an educational history that boasts an extremely broad pedigree, including the All India Institute of Medical Sciences, Harvard, the Houston Methodist DeBakey Heart and Vascular Center, and the London School of Economics and Political Science in the UK, just to name a few. He has contributed close to 300 scientific manuscripts and epitomizes the contemporary academic. Over the last several years, Dr. Kalra's academic interests have pervaded the realm of philosophy, including a deep study and synthesis of one of the most influential ancient philosophical discourses, the Bhagavad Gita. In this context, I am absolutely thrilled and delighted to introduce Dr. Ankur Kalra, who will be integrating his experiences as a physician with the lessons learned in his studies in philosophy, as he will be speaking on religiosity and spirituality in medicine. In our profession, in the medical profession, it has come to light that technology has far surpassed our ability to integrate all of these efforts within the care of our patients. And in that race to provide the best care, sometimes we lose track of who we are as human beings and what our ultimate goal is. Our essence as human beings and our root in spirituality is something that we need to take interest in. And I think that Ankur will allow us to frame shift ourselves back to who we are. And for this reason, this particular grand rounds in religiosity and spirituality, I would consider as paramount for our listeners here today.
Well, thank you for having me, and thanks for the generous introduction. I know this could be an esoteric topic, so just a raise of hands. How many of you believe in the concept of mindfulness? Just a raise of hands. Okay. And how many of you practice it? Okay. Well, I'll tell you an anecdote from this morning. So I got a really nice email from Elizabeth yesterday, and Heather was copied. And I was told that I'm supposed to be in room 326, and it's the Van Nuys Medical Building. So, like I prepare for any talks, I Google it and I look at the distance from my house, and I planned the ride this morning. So I get her at 6:50. And then it's a nice, cool morning. And then it's like, oh, this is going to be a nice walk up to the building. And then I enter the building, and then I can't seem to find the third floor. It says in this building, it says floor 1, floor 2, and then it says floor 4 and floor 5. And then there's nobody around for me to ask. So then I start getting a little nervous, like I'm supposed to be doing a grand rounds talk, and here I am, and I can't seem to find 326. So I pull up the email from Elizabeth, and there it gives a cell phone number for Heather. She was very kind. So I dial the cell phone number, and it says that it's switched off.
I'm in this service.
So then I said, okay, maybe there's an issue. So let me just send a text. So I send a text that I'm here. I actually take a picture of the lobby where I'm at, and I send that picture. And apparently, do you use an Android?
Yes.
Yes. And I use an iPhone, so you can't get the delivery report. So you see how it keeps getting better. And then I said, okay, well, let me just write an email. So I write an email. And knowing that it'll be hard to get a response at like 6:55. And then I'm like, okay, I'm just going to practice mindfulness. I'm here. I'm in the moment. Everything is fine. It's beautiful outside. I'm healthy. My kids are healthy. It's going to be okay. And then in 10 minutes, I hear from Heather. So with that preamble, again, thank you for having me. These are my disclosures. And we're going to start talking about religiosity and spirituality in medicine. And I thought that for this talk, I'll break it down to to two sections. I'll give the patient perspective, which was the piece which was published in the European Heart Journal in 2021, and then I'm gonna bring the physician perspective. So I think it's important to look at this from both the patient side and the provider side. So this is the paper. It's titled "Heart, Mind, and Soul: Spirituality in Cardiovascular Medicine." It's interesting. There's an anecdote to this paper which I'll share, but let me present the patient perspective first. And I want this to be interactive. So at any point in time, if you have any questions, feel free to raise your hands and we can have a dialogue. So spirituality, how you define spirituality, and I think there's an overlap between spirituality and religiosity, and that's why I put the front slash. And these terms are interchangeable, but there is a slight difference in that spirituality is naturally occurring phenomenon where one seeks a connectedness with a higher purpose or force. It lies outside of ordinary existence and inherently is associated with an overarching meaning of life. So experiences like oneness and unconditional love, they may occur within the religious context, but they are very personal experiences. And although mindfulness and yoga are secular spiritual practices, and this is why these terms are interchangeable, these practices are very secular and they're not associated with any particular religion. They were developed within the broader context of Buddhism and Hinduism, respectively. So mindfulness comes from the Buddhist school of thought and literature, and yoga comes from the Hinduism school of thought and literature. The limitation is that spiritual experiences and how people define them, and when they start talking about them, and people who haven't experienced these or have had these experiences in life, because each one of us are on our own paths, it may not objectively fit into parameters of language per se, because it's actually a feeling, that assesses emotional, behavioral, and cognitive measures to describe it. And these experiences occur in wordless states. What one defines as God or divine may not apply to someone else having the same experience. So it's difficult to quantify. It's difficult to measure it. So for a scientific audience, who are very pragmatic and data driven, it's sort of quote unquote out there, unless you experience it yourself, and then you realize that it's real, and then you sort of seek the literature behind it, which was sort of my journey when I experienced this in 2018. So, this is a diagram from the paper, but I think, I'm sure all of you have looked at Venn diagrams and also have come across a very popular social media figure which talks about ikigai. Do you know what ikigai is? It's the perfect spot in the Venn diagram which meets your vocation, gets you a salary, is your hobby, and serves a purpose. And if you check all those four boxes, then the middle portion of that Venn diagram is your ikigai. So similarly, I think spirituality encompasses all these facets in our life: perception of health and disease, our own lifestyle and habits, the healthcare choices we make, our patients make, and cultural and moral norms. And I think if you look at all these facets of life, spirituality encompasses all of them, and sort of is the final common pathway of decision making for a lot of patients, including us as providers. So let me talk a little bit about the physiology of spiritual experiences, and this is getting to the science of spirituality, if you will. Maybe an oxymoron, but I'm going to do my best. Close proximity of data actually come from meditative practices to spontaneous experiences, which form basis for an understanding of the neuropsychophysiological effects of meditation. And people have studied this, and they've tried to bucket this in two aspects. One is arousal, and the other is relaxation. And you can attain spiritual experiences by both arousal and relaxation. And I'm going to give you some examples. So this is, again, it's a schematic from the paper which we published in the European Heart Journal, and I can share copies of the papers with Heather for distribution in case anyone is interested. So arousal. So before I even start to go through the schema here, think about it in terms of the systems. So the autonomic nervous system is where it all starts. And then it percolates down to endocrine and the immune system, and then the central nervous system. So let's talk about relaxation first, because that is where most of the meditation works. What happens with meditation is that you start accessing alpha and theta waves, which most of us don't have access to in our normal states of consciousness. And when that happens, there is a predominance of parasympathetic activity, which then results in controlled hormonal and inflammatory responses. And I'm going to share some examples, which then results in a decrease in anxiety, stress, and depression. On the contrary, arousal, which actually is a form of meditation as well, it's called tantric meditation. It's very popular in the East, and certainly in India. There is an increase in the sympathetic tone, which has an effect on the inflammatory cascade and oxidative stress, and causes an increase in psychosocial stress factors. Now, how that actually works to attain a meditative state, I do not know, because I'm of the relaxation school of thought, because that's the one that's helped me, as a person and as a physician. So mindfulness, I'm going to try and define mindfulness. It's a moment to moment. I'm going to take some time defining it. And if you have any questions, please feel free to raise your hands. It's a moment to moment, non-judgmental focus on the content of one's mental and physical experience, and a progressive awareness of its presence. To the point that when you're taking a flight of stairs, you're mindful of taking each step, and you're mindful of every breath, and you're mindful of every word that you're saying, and you're mindful of every person that you are seeing. So you are actually in the moment. And a good allegory for me, at least as a proceduralist, is either in the operating room or in the cath lab, because that to me is the most meditative state in my own consciousness. I am very in the moment when I'm in the cath lab. I am not thinking about the response to reviewers to a paper. I'm not thinking about chores at home. I'm not thinking about what I have to do in the evening with my kids, or what I have to have for dinner, or what I have to have for lunch. I'm so in the moment. I'm so in the moment with the steps of the procedure in front of this. I'm looking at the screen in front of me, and I'm so in the moment that I do not think about anything else but that moment alone. And that is a true meditative state. I mean, that's what meditation tries to do. The meditation tries to bring you in the now, in the present. And so this is anesthesia, so all of you are very facile with how the ORs work. And I think if you think about moments when you're completely in the now, at least for me as a proceduralist, is when I'm actually doing a procedure. It's very meditative for me. And so that's the concept of mindfulness. So if I can extrapolate that essence, or that being of being in the OR or in the procedure room, to my life outside the OR or the cath lab, I think I'll be living in a very meditative state. But it's very, very hard to do, because we all have a monkey mind, and we keep having thoughts one after the other. And it's just an incessant train of thought. And the idea of living a mindful life is to just being in the moment and being in the now, so much so that the only thing you're thinking of is the now. Because the minute you think about the now is gone, and then you have the next moment. Transcendental meditation is using a word or a phrase and trying to return to attention. So if someone, which is how people actually start meditation, they usually sign up for a class. There is a teacher or a seasoned practitioner of meditation, and he or she is going to give you a phrase or a word, and you keep chanting that word and keep focusing on that word. The most common one is Om. Ramdas, who's the late Richard Alpert, would keep saying, be here now, be here now, be here now. And I'm loving awareness. So I think these are some of the words or phrases that seasoned practitioners use to bring, each of us back to the now. Again, the more you practice, the better you get at it. So both techniques have shown to result in a wakeful hypometabolic state of parasympathetic predominance. And what that does is it actually decreases heart rate, blood pressure, and respiratory rate. Now, there is a contrasting technique, and I think I alluded to this when I was going over arousal, and that is the technique of Vajrayana, which is a meditative technique, which is a technique of single-pointed concentration and visualization, and it leads to aroused wakefulness. I've never practiced this, so I can't speak much about it, but I can attest to the wakeful hypometabolic state of mindfulness and transcendental meditation. So, I'm going to talk about some of the hormonal and immunological effects which have been demonstrated through studies. And, investigators have shown a decrease in NF-κ beta activity. They've shown a decrease in circulating levels of C-reactive protein, which, all of us know is an inflammatory marker. It's been shown to be of causative mechanism, even in acute myocardial infarction. And there was a neat study done in HIV positive patients in which they showed that those who were subjected to transcendental meditation actually had an increase in CD4 plus cells, which was independent of the antiviral therapy that they were on, which I thought was fascinating. Now, there's one study, and I've put this as the last phrase here, which is telomerase activity. The telomerase length is associated with our biological age. So our chronological age is, 40 and 41 and 42. And then we have a biological age where we could actually be younger than the chronological age. And there are studies out there which have shown that in people who practice meditation and mindfulness, their telomerase length is longer compared with those who do not practice mindfulness and meditation. And the longer your telomere length is, the less your biological ages, irrespective of your chronological age. And then you have neuroimaging, in which it has been demonstrated that people who regularly meditate, particularly, and this was done in the monks actually, there was an increase in the activation of both the frontoparietal lobes, which is the center of intelligence, and also the thalamic and the limbic system, which controls our emotional intelligence. So there is the IQ and there is the EQ, and there was an increase in both. There's an increase in the activity in both these centers in the brain, both IQ and EQ, in daily practitioners of meditation. And, this study was from University of Wisconsin, in which they looked at some of the monks and did MRIs on them. And that's what they found. So this is pertaining to cardiovascular outcomes. And this was the focus of the paper. It was published in the European Heart Journal. And it's funny, like each time you write a paper like this and you send it to, the Journal of the American College of Cardiology or some of the American journals, it's like an instantaneous desk rejection. And then this has been my experience, at least. And, both are, very highly read journals in cardiology, the European Heart Journal and the Journal of the American College of Cardiology. And then I turn around and without revising, I send this to the European Heart Journal, and it's a desk acceptance without any revisions. It's funny how, the American journals are still, resistance may be not the best word to describe it, but not as receptive to these concepts as the European journals are. These are some of the data pertaining to spirituality and religiosity and cardiovascular outcomes. There was a study which showed that infrequent religious attendance was associated with higher rates of cardiovascular mortality over a follow-up of 31 years. And this was replicated in the Nurses' Health Study, which actually showed a 33% reduction in all-cause mortality among women attending a religious service more than once a week. Coming to transcendental meditation, there was a 48% reduction in all-cause mortality during almost a 5-year follow-up, with a 24% risk reduction in the composite secondary endpoint of cardiovascular deaths, revascularization, and cardiovascular hospitalization. And then I'm sure all of you interface with atrial fibrillation as anesthesiologists, and you see a lot of patients with atrial fibrillation. There is a well-established connection with the autonomic nervous system and the genesis of atrial fibrillation, because in patients with atrial fibrillation, there is an increase in the sympathetic tone, which causes vagal overcompensation, which causes a shortened refractory period, which causes atrial fibrillation. And there is published literature in the cardiovascular space, which has shown that you can diminish the burden of atrial fibrillation with yoga training. And you can do that because yoga, like mindfulness, like I said in that schema, works on the autonomic nervous system and increases parasympathetic activity, decreases the sympathetic tone. And that has both effects on the hormonal and the immune system, but also on the central nervous system. So, when it comes to, at least in the cardiovascular literature, and I don't know about other specialties, there are studies which have shown all these four aspects: decrease in all-cause mortality, a decrease in major adverse cardiovascular events, decrease in arrhythmic burden, as well as a decrease in the burden of risk factors, so risk factor modification, because not only did spiritual practices help decrease all-cause and cardiovascular mortality, they also helped, mitigate worsening of some of the risk factors like diabetes and high blood pressure. So with that, I want to deliberately stop here for a minute or two and entertain any questions from the audience, because I'm going to be switching to a provider perspective from a patient perspective. Any questions? Yes.
Probably those just this room or typing personally or big experience. How do we break that cycle and give forgiveness for ourselves as far as finding happiness?
Excellent question. You could not have asked a better question, because this is the perfect segue for the second segment of the talk. So the answer is the slides that are going to follow. All right. And this was not staged, by the way. This is so a medical crisis is also a spiritual crisis, and physicians and providers are recipients and witnesses to the diverse expression of spirituality. And it's important to assess spiritual needs, of both, I think, patients as well as providers and their loved ones. And physicians or providers, patients, and their family members together explore spiritual and ethical issues, and we do this on a day-to-day basis without even realizing it. So this is a paper which was published last year in October, and I think within a week after it was published, it had 10,000 downloads. And I'll be happy to share this paper with you, because I think it resonated with the question that you asked, and it resonated with a lot of the cardiovascular providers and professionals who, like anesthesiologists, or I think physicians at large, are type A go-getter, intense personalities. So I'm going to be sharing two vignettes. Sorry if this is blurred, but I'm going to do my best to read it. So I think it should be okay. A 57-year-old woman newly diagnosed with metastatic lung carcinoma is hospitalized for dyspnea. A clinical diagnosis of cardiac tamponade is suspected and confirmed by 3 cardiologists after reviewing echocardiography findings. Following discussion with the patient's oncologist, urgent pericardiocentesis is uniformly recommended. Doctor, is this necessary? Will I be okay? How serious is this? She frantically asks. You reassure her and her anxious family, educating them about the need for the urgent procedure. She provides informed consent, hugs her family, and is wheeled into the catheterization laboratory. Using echocardiographic guidance, you access the pericardial cavity with a micropuncture needle, wire, and sheath, confirming placement with an agitated saline study. You have done this dozens of times. You are well versed with the highest standard of care in such scenarios. Verifying satisfactory positioning by transthoracic echocardiogram and fluoroscopy, you drain 200 cc's of serosanguinous fluid. As you continue to aspirate more fluid, she collapses. Pulseless electrical activity. All frantic resuscitative efforts are futile. The time of death is announced. Stillness and shock stifle the room. Second scenario. A 42-year-old man is resuscitated in the emergency room following ventricular tachyarrhythmia arrest. An electrocardiogram is consistent with an inferior ST elevation myocardial infarction. You inform his shock-ridden wife of the need for emergent coronary arteriography. The patient is rushed to the cardiac catheterization laboratory. There is evidence for acute plaque rupture in the proximal dominant right coronary artery. Ventricular fibrillation ensues. In accordance with the highest standards of care, the patient is successfully defibrillated, and you perform the indicated primary percutaneous coronary intervention. Epicardial flow is instantaneously restored. The patient is monitored in the cardiac intensive care unit and sent home days later on appropriate guideline-directed medical therapy post-acute myocardial infarction. During a follow-up visit a week later, he's accompanied by his grateful wife and 10-year-old daughter, who brings you a handmade thank you card along with a box of treats for your staff. Joy and laughter fill the room. So what I've described here is two scenarios which have happened to me in person. These are my own personal anecdotes. And these are two disparate outcomes. They're completely opposite to each other. And on one hand, there is joy and there is fulfillment and there's great victory. And on the other hand, there's defeat. And as clinicians and as proceduralists, all of us are going to face scenarios like this, where we show up to work every single day as who we are, with the same amount of dedication, same amount of training, same amount of knowledge, perhaps ever increasing knowledge. And we are going to do what's best for the patient to the best of our abilities, and we're going to have completely opposite outcomes. So how do we reconcile with that is what I'm going to be sharing in the slide sets. So this is a very popular verse in the East, in India, at least it's a way of life. And it's from the Bhagavad Gita, which is my spiritual guide. And this is a verse from chapter 2, it's verse 47. And the interpretation of the verse is as follows: the only thing you have any control over is the work that you choose to do at any given time. The outcome of your efforts is not in your hands, which is an antagonistic, it's a revolutionary concept in the West. Because in the West, we are so outcome driven. We measure outcome. We do anything and everything to measure any and every outcome. And I'm going to talk more about it. But the fundamental principle of paradigm shift or tectonic shift here is that the outcome is not in our hands. You should neither take the outcome personally nor fall into the trap of thinking that doing nothing is better. This may require, more teaching or more insight to understand. And I'm happy to share my own insights. And if anybody wants, I can read this again. I think I'll just read this again, and I'll read it slowly because this is very important to understand this concept. The only thing you have any control over. So in the Stoic, I don't know if anyone follows the Stoic philosophy, the Stoic literature. In the Stoic philosophy, it's called the dichotomy of control. And this is how the Bhagavad Gita calls it. The only thing you have any control over is the work that you choose to do at any given time. The outcome of your efforts is not in your hands. You should neither take the outcome personally, nor fall into the trap of thinking that doing nothing is better. So the Bhagavad Gita is an ancient text that influenced the life and works of Mahatma Gandhi, Martin Luther King Jr., and Ralph Waldo Emerson. It's a playbook for living an extraordinary life of dynamism, purpose, and joy. In an exceedingly pragmatic manner, the Bhagavad Gita asks us to focus on a given task at hand, perform it to the best of our ability, and then allow the chips to fall as they will. I mentioned the Stoic philosophy. The Stoic philosophy calls it the dichotomy of control. So letting go of outcomes, some people say, well, the Bhagavad Gita is teaching you to let go of the outcomes. So you mean that you're shirking responsibility. It actually is the opposite. It is not shirking responsibility. It actually paves the paths to owning up to one's responsibility without guilt, blame, or self-pity. So I'm going to give you an example here, which I think is easier to understand. And that is, archers have control over whether or not they obtain the best bow and arrow, their quality of training, and the extent to which they practice archery. Now, whether the 100th arrow will hit the bullseye the same way the previous 99 did is actually not guaranteed, because subtle wind is enough to deviate it. So as healthcare providers, we must practice medicine through well-intentioned, evidence-based, and timely decisions. What's in our control is planning ahead, is ensuring skilled and rested personnel, is appropriate equipment and resources. How a given patient will respond to therapy is not in our control. As much as we think it is, it isn't. Yet modern American medicine is driven by metrics. I mean, all of us are aware of this. And I'm going to enumerate all the metrics that we measure ourselves up against or we have quantified. Health systems continually vie for top spots in national and regional rankings. Every action by a healthcare provider generates a data point. Clinics are split into slots for utilization efficiency. Operating rooms and procedural laboratories push for efficient turnaround times. Clinical outcomes are reported juxtaposed to national benchmarks for safety and quality. And then you have the patient satisfaction surveys. So while such metrics are developed to ensure accountability and improve processes, and I'm all for improving processes, they place undue importance on what lies outside the scope of our control, and that is outcomes. What lies in our control is the effort that we put in. What does not lie in our control is the outcome. So irrespective of complexity or diligence, positive outcomes are lauded, negative outcomes are disincentivized. And that leads to an unsavory effect of fostering blame and casting judgment, which leads to burnout. How then do we reconcile the concept of letting go of the outcome with our fundamental desire to making patients feel better and live longer? I think that's a question that I asked when I examined the Bhagavad Gita. And how can we remain unattached to the results of our actions when they are tallied and surveyed by authorities that can, quote unquote, make or break our careers? I think these are fundamental questions that will pop into each of our minds when we listen to a talk like this. So aiming for the best clinical outcome remains critical, right? It is our North Star. And I think everything that we do in preparation is for having an excellent outcome. And that is what we should do. So the prerequisites are apt preparation, developed expertise, owning our skills and communication. Since no outcome is in our direct control, we must only focus on our energies in the present moment, on honing and perfecting our skills to the extent where employing our knowledge is the outcome. So the action itself is the fruit, not the outcome. So with each passing moment, the only thing that you can do is the amount of effort that you're putting in and your own action. You cannot control the outcome. I think if you fundamentally understand this concept, you're going to do away with a lot of burnout, and you're going to start finding new meaning in life, that the only thing that you can control is your action, and anything that happens afterwards is not in your control. And you should just let go of that feeling of control. The downstream effects of the downstream effects of the thought process are a continuous stream of new events, each met with presence, each met with skill and knowledge to the best of our ability at that time. So performing the appropriate action and anticipating the best outcome should be the focus, but there should be a deeper knowing that all possibilities exist for any outcome. And I think as long as we can reconcile with that as clinicians, I think that to me is the key to preventing, physician or clinician burnout. So the critical teaching of Gita is not anticipating a good outcome, but letting go of the attachment of any particular outcome, good or bad. And we ought to remind ourselves that we became healthcare providers to make a difference. But if we remain attached to what that difference is going to look like, we will forever remain vulnerable to burnout. Maybe that answers your question about how to find happiness. So Gita lessons in mitigating burnout. So humility to continue learning, ongoing desire for growth, commitment to serve to the best of our ability, and taking grief and joy in stride, ever focused on the present moment rather than the results of our actions. So that concludes the second sort of section of my talk, and I have a resource library for any of you who is interested in this literature. These are some of the other papers I wrote for the European Heart Journal, COVID-19 and the healthcare workers at the time of the pandemic. Also extrapolating from the Bhagavad Gita on how we should deal with the pandemic as healthcare providers. And then, how many of you are familiar with the second term Schadenfreude? Okay. So it is, it's unfortunate that it exists, but it does. And that is the human nature of seeking pleasure in someone else's misery, unfortunately. It sounds horrible, but it exists. And it's actually very prevalent in medicine. And this was at least my own perception. When I was part of academic medicine. And, does the desire to succeed at all costs result in a detriment to the individual soul? Was what I examined in this paper. If anyone is interested, I'm happy to share a copy. But I think this is, again, it falls into the same purview and literature of, self-exploration. And then this is a paper which just came out this year, again, talking about how we can learn from the monks to be better physicians. It's the physician and the monk, also published in the European Art Journal, because none of the American journals would take this, and the European journals just take this in a jiffy. So, I've at this point that's become my pathway of least resistance, and that's where I send all my writings to. So I'm happy to share this if anyone is interested. And finally, this is a colleague of mine. He's the program director of cardiology fellowship at the Mayo Clinic. His name is Dr Nandan Anavekar, and I found a companion in him, in that his understanding of the spiritual and theological literature and how he applies those teachings to modern medicine, have resonated with me. So I host a podcast which is available on all the podcast platforms, and it's not only cardiology; it actually talks a lot about such concepts within medicine. And I recently recorded a mini series with him on self-exploration and outcome-focused cardiology, but I think it could extrapolate to all of medicine. So if anyone is interested, feel free to take a listen and share feedback. I'm open to feedback and conversations like this. I think my final thoughts are that in India, or in the Eastern literature at least, there's this concept of Sangha, which is togetherness. So I think if we are together in our spiritual paths, we'll get to our destination sooner. And so the more, the merrier. And with that, thank you for having me. I think it was an honor and a privilege and a pleasure.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.